So I want to move into something that we call anatomical connections here. And actually just, we kind of alluded to some of this already, but just helping you to understand that the knee isn't just iso. Yes, we always, when we're talking about treatment, we'll go in isolation and focus on the knee. But we kind of already talked about this before, the importance of really pulling the hip into treatment or pulling the ankle into treatment. One of my favorite things to teach patients and to empower them on is the understanding that there are actually these very predictable cross patterns, what we
Mm-hmm.
actually call the most classic one that people probably know is like the upper cross, where it's like I sit here, so therefore the back of my neck is tight, the front of my pecs are tight, and then the opposite, like the front of the neck is elongated and weak, and the back of the shoulders is elongated and weak. That's not what we're talking about here. We're actually talking about the knee down here. So we actually have a very predictable strong to weakness, like alternating pattern. And what typically happens is down at the knee, above the kneecap, there's the vastus medialis and vastus lateralis. Those are all parts of like the quad muscles.
Mm-hmm.
And quite frequently, rectus femoris tends to be way too weak on a lot of athletes. It's surprising when you go to test that and you just like push it right down into the ground, and you got like that athlete that it's like, but I could like squat like, 300 pounds. It's like, yeah,
Mm-hmm.
you could squat 300 pounds, but your rectus femoris can't stand the slightest breeze without blowing over. So that's
Mm-hmm.
why you have knee pain, right?
Yep,
um,
absolutely.
but you get that weakness through the front, and typically that's going to be accompanied by hamstring muscles that are way too tight, way too overactive. Now, usually there's a cross, but we find at the knee it actually doesn't cross. It actually kind of all stays on the back there. So we have like the tight, overactive hamstrings, and then we also get the tight, overactive calves. And then it's actually the front muscles on the front of the shin that tend to be a little too weak. So, like the tibialis anteriors and whatnot.
Mm-hmm.
Not 100%. We can't like look at somebody and say, I guarantee that's what it is, but we can make some pretty good inferences just because we know what lifestyles are. We know that many people spend way too much time sitting. We kind of know sort of like the adaptive behaviors that people fall into when they're walking and running to kind of work around like insufficient ankle mobility or an overweak glute. And those are just kind of like the ways the body just ingeniously adapts around things, but sometimes the rent comes due and the pain shows up, right?
Absolutely.
Yeah. So that's kind of what I wanted to share as far as an anatomical like connection, global connection. Was there something you wanted to contribute on that, Rebecca?
Just honestly, like kind of correlating with you, but I also look at joints. So not only the muscular tightness and tension and everything like that, but we kind of mentioned ankle mobility a couple of times, but
Correct.
sometimes that joint can actually be locked in itself, right? So less of a muscle tension, or it could be contributing because of muscle tension, right?
Mm-hmm.
But lack of mobility either in the great toe, the midfoot of your the bones in your foot,
Yes,
or like
yes.
that ankle, your classic ankle, what you think of as your ankle joint, right? That all can contribute to like lack of mobility or hypermobility there can
Mm-hmm, mm-hmm.
also contribute to some of that knee pain. And same thing at the hip, right? If you have restrictions in your hip or your mobility in your hip, that can also contribute to that knee pain because it may increase that Q angle that we talked about, or
Yeah.
decrease it, or change the way that you're moving, change those muscle pulls, which then causes some of that tension too.
Yeah, I love that you elaborated on that. And what I also think is, I was listening to you, but I was also laughing inside. It's like, isn't this just messed up that basically you had the chiropractor talk about the muscular problem and you had the massage therapist talk about the joint restriction? Aren't we supposed to like flip that around? But hopefully, what that illustrates to everybody out there is that we do not put ourselves in a box. I think
Mm-hmm.
both you and I pride ourselves on really actually taking that extra 5 to 10% step working with patients, and not just thinking like I'm a massage therapist, I'm just supposed to look at muscles.
Right.
And I'm certainly not I'm a chiropractor, I just move joints and bones. It's called the musculoskeletal system for a reason. You
Absolutely.
kind of can't really completely tease these two areas out, and I think if you just only really look at one and assess one and you drop out the other, you're not going to quite get the full results you want to get with patients.
Definitely.
So
And I think it's great that we have these conversations too and can go cross collaborative, because then it's like I learn, he learns, right? We can both bring that into our practices too and
absolutely.
help our patients better.
Yeah,
So,
absolutely. So
yep.
now